So I think Dr. Sneed has joined us, and I'm going to go ahead and introduce him. But I did want to say, I think right now, Dr. Austin may be the only primary member of our core group that's on. I don't see Mr. Green or any of the others, but they may show up as the program ensues. So again, Dr. Berry, thank you for lending Dr. Austin, Mr. Morgan to help us. We are grateful and appreciative of your leadership and certainly your support, because if it wasn't for you, again, we wouldn't have made it this far. So as I mentioned, I'm serving as the program director and associate dean of clinical affairs for the Tanasia College of Pharmacy. But I have had the pleasure for the last nearly 11 years to work under Dr. Kevin Sneed, who is, like myself, a pharmacist, but he also is a career academician. And he actually, unlike me, went to Xavier University. I went to Florida A&M University, but we met actually initially during our tour when we both were working for Florida A&M University. And one of the things that I can honestly say about Dr. Sneed is that he's a man of his word, he's a man of integrity, and he has a place in his heart for the community. And he's not only a leader, but a servant leader. And that is so really important because he understands the importance of giving of himself, and making a difference for those that may be in some cases underserved, underrepresented, or less fortunate. And that does not have any reflection on making him better than anyone. And he doesn't think himself as being better than anyone. So when he greets you, if he calls you his friend, take that as a compliment, because he is certainly a man that you would love to have noted as one of your friends. Dr. Sneed, as I mentioned, completed a degree in pharmacy from Xavier University, but he actually started his secondary schooling at University of Florida. He had an aspiration of becoming an athlete, but unfortunately, he endured a slight injury that caused him to kind of end his athletic career a little early. He transferred to University of Central Florida because Orlando is actually his home. And from there, he actually started studying microbiology and immunology. And who would have thought 30 years later that he'd be able to put that to use the way he has? But he then went on to Xavier after studying microbiology and immunology. And he was actually on his path to getting his PhD in that area. But I'm grateful that God saw fit for him to become a pharmacist. He went on and did a residency in ambulatory care over at Bay Pines in St. Pete. And from then on, he's worked in hospitals. Like many of us, he's done his share of community practice as a pharmacist, always been involved in community service. He's a member of Kappa Alpha Psi fraternity. He is a family man. He is a God-fearing and God-serving man. And certainly for those of us that work under him at the Tanasia College of Pharmacy, we see him both as a leader as well as a, again, person of integrity. So today, I'm sure he's going to enlighten all of us about some of the latest and greatest things that are going on with the pandemic. Again, we know with every day there's been a change in terms of the information and data out there. So I will stop talking and introduce to some and present to others, Dr. Sneed.
Well, Dr. Hill, my great friend, thank you very kindly for that introduction. I really want to thank Reach Up Incorporated first and foremost. Of course, our wonderful friend Deborah Austin, Dr. Austin. We never could have imagined 3 or 4 years ago when we all started working together that 3 or 4 years later we would be kind of partnering on something that has become such a scourge, not only here in our country but around the world. And so I'm very thankful for all of you, and for all of you here today. I'm just thankful that you're taking the moment to to hopefully learn something new. I'm going to go through a presentation. Portions of it are going to go pretty quick because I really want to get to a question and answer. I know many of you have a lot of questions. I think I have an answer to most of your questions out there, maybe not 100% of them. But as a backdrop to the presentation I'm about to share with you right now, and I'm going to share my screen here. I think that should be the right one. All right. As a backdrop to this presentation, one of the things that has really come up, or even around Omicron over the past 3-week period, there's a lot of confusion going on out there, and I'm hoping that we can dispel some of that confusion. But the first thing I want to tell all of you is that there's not one variant that we've had in our country that originated in our country, that originated here on the shores of the United States of America. And so over time, as we have had to deal with multiple surges, every variant that came along has been a little bit different than the one before it. It had different characteristics, and I'll be happy to address that with any of you. So I'm hoping that my presentation will spark some thoughts and questions from you, and we can have a really good conversation moving forward. I'm going to skip past this video just for now. Many of you have seen it before, but just for time's sake, and I do apologize for being a little bit late here. I'm just coming, as you see, I'm just coming from seeing patients in the clinic. But again, this is a very important slide for a lot of reasons. I'm going to spend a moment talking about this. If you look all the way on the far left, the coronavirus as a family of viruses, okay, as a family of viruses are not new. We've been dealing with coronaviruses for a very, very long time. And for many of you prior to this pandemic, if you ever had the common cold or even the flu, it's been estimated that about 15 to 20% of those now. I used to say, up to 10%, but now we're estimating about 20% of those were probably caused by one of these what we call common coronaviruses. And so they've been circulating around the world for a long time. Now, back in 2002, we had what we call SARS, and I'm going to call it SARS-1, and that proved to be very deadly. We had about 8,000 cases of it, and it killed about 10% of the people infected. For one reason or another, we got very lucky, and SARS-1 just kind of magically went away without any true intervention of anything that we could have done as human beings. About 10 years later, we had MERS. You all may recall that. We had even fewer cases, but that proved to be even more deadly than the original SARS-1. Again, about 2,500 cases, and then about 850 of those people died from that really small number of people. So we had more people die from MERS than we did with SARS-1, even though we had far less cases. And so now we're dealing with COVID-19 that originated back in 2019. That's when it was identified. And so current numbers, we're up above 65 million people in our country who have been infected. We are now at about 855,000 people who have died. Globally, about 6 million people have died overall. So, we're talking about what has turned out to be by far and away the deadliest version of any coronavirus that we've dealt with in recent times. And so one of the things I really want people to understand is that this virus has continued to evolve over time. Most of it has evolved not inside of the human race, but inside of animals like bats. And so what we are hoping that we can do is to continue to educate people, because we don't know what the future is going to hold. All estimations right now are that even though we're dealing with this coronavirus in the midst of a continuing pandemic, the pandemic part is not over. We're still in it right now. But we're already bracing for the fact that we may have an even more dangerous version of this particular coronavirus that we're dealing with in COVID-19, anywhere from 6 to 9 months or even a year down the road. So we just want to make sure that people understand how it continues to evolve over time. Now, I put this slide in because many people have this belief, and again, I'm aware that there are many sources of information out there. We're getting information from Facebook, we're getting it from TikTok, we're looking at 5-minute segments with Dr. Fauci in the evening. There's a lot of swirling bits of information, but in the research world, we take all of our information and we print it down, and it's according to the evidence and the fact of what we have observed during research. And so many people feel that, well, I'm strong, I have a strong immune system, I've never been ill before, and we get that, we understand that. But let me explain to you exactly what's happening with your immune system. Now, what you're looking at here, actually, this was published back in 2020, in May of 2020. And so if you look at the black dotted line, we can see exactly when most people get infected. It just popped up in the that blue area. And then it takes about a week before your body really recognizes that it's even been infected, okay? And then about a week after that, with the original version of the coronavirus, okay, the one that infected people back in 2019 and 2020, it would take about a week or a week and a half for your body to begin the process of building antibodies against that particular virus. So again, let's make sure we understand, even if you've never been sick before, if you had mild colds, or even if you had the flu before, until your body encounters a particular type of virus, you don't have antibodies built against that particular virus, okay? I know many people believe that, but we don't. Your body has to manufacture antibodies against a particular virus at the time it encounters it. Now, I'm going to back up here and I'm going to explain something to all of you. You can see that time period I just put there. Part of the evolution, I'm going to go back here because I put something here. Part of the evolution of this current coronavirus that we're dealing with right now with COVID-19 is the fact that it learned how to, in the very beginning, when it infects you, when it gets into your nose, I'm going to show you that in a moment. It actually has a way to, what we in the medical world we call evade. It has a way of evading your natural immune system. Now, the early alert, we'll call the innate immune system. Okay, it evades it. Your body doesn't even know it was there. In more common language, and so now we're back here. In more common language, I call that it has a skill to almost deactivate and hold off the early alert immune system. It will be in your nose for a period of time before your body even knew it was there. But during that time period, it is replicating at a very high rate. So this is part of the evolution of how this particular virus has now almost outmaneuvered our natural immunity that we are all relying upon to protect us. Now, this, what you're looking at here was from a year, back in 2020, almost pretty soon it will be 2 years ago. What you're looking at here was published last week, okay, or almost 2 weeks ago now, on January 7th. You see that black dotted line, and it says onset of symptoms, and then you see that the kind of yellow box area. It's the very same thing. It has invaded your nasal area. It's replicating now at a very high rate, and your body doesn't know it is there, okay? It just is not responding to it. Now, if you look here, beginning at day 7, you see that kind of yellow orangish line, the IgM. That's the beginning of your body beginning to build antibodies against the coronavirus. In this case, we're going to just say Omicron because I'll show you in a moment, almost everything is Omicron right now. And then a couple of days after that, you begin to build the long sustaining version of the antibody, the circulating one that will last and persist for months at a time, is the IgG. So again, to go back, here we were showing 2 years ago that it would get into your nostril, your body wouldn't know. And 2 years later, we are still showing the very same thing. Now, it's very important to understand, and I know this cartoon can be a little bit confusing to look at. And so now I'm going to pull all of you into my scientific world to help you better understand what we're trying to do to better understand it so we can build medications and better defenses against this coronavirus infecting your body. But now I want to help you all understand what's happening when it gets in your body. If you look at the very top, you see the coronavirus there with the little spike proteins on it, and then it has a little receptor, the circle called the ACE2 receptor. This is part of your cardiovascular system. It's part of your cardiovascular system, okay? Not just your lungs, I'm talking it innervates and has parts of every organ inside of your cavity right here, from underneath your collarbones all the way down into the pelvis. I'll show that in a moment. When the virus, when it gets into your cell, it is now going to unfurl and it's going to begin to try and replicate itself. Okay, so I'm not going to worry about this non-structural protein part for right now, but as it moves along, it's going to gather proteins from your cells, and it's going to take over the instructions of your cells, and it's going to tell your body to take your proteins and remanufacture thousands, and I mean hundreds of thousands of copies of that virus, and then go back out into your bloodstream and go back out into your body. So that's what we're showing here. This is how viral replication occurs, and almost all viruses have a very similar cycle. The difference here, I'm going to go back, that non-structural protein, it has now learned to deactivate, to turn off, to evade the early part of your immune system, so that it has a chance to replicate at a much higher rate long before your body, your human body, can actually detect that it was there. And that's why when we go back and look at these different areas, that's why we figure out, that's what we call that an asymptomatic stage, a pre-symptomatic stage, but it's replicating the entire time. So let me continue to move along here.
Dr. Salim, would you stop just a moment and let someone into the meeting?
Oh, absolutely. Let's see here.
Thank you.
Okay. I'm just going to admit all of them. Okay. All right, we got them all.
Thank you.
Okay, perfect. Okay, moving right along. So here I'm showing what happens when you inhale that virus because you were, at the wrong place at the wrong time. Okay, because somebody's putting that virus up into the air. And when people lose their sense of smell and taste, I'm just showing you an example. We're doing research to figure that part out. What's happening to the cells in your body that you would lose your smell and or your taste? And actually what we're finding out is that this becomes an entryway, more than likely, for the virus to gain entry into parts of your brain. And that causes some of the brain fog, we believe, and other either gray matter changes in the brain. So I just wanted to kind of share with you that these are the kind of research things that are going on all the time. Now, as I mentioned before, many people think, oh yeah, the virus, it's a respiratory virus. It's just like the flu, is nothing more than the flu. I have a stuffy nose, which is a hallmark sign of Omicron right now, by the way, and I'll explain that later. I just want to help people understand that this virus can attach onto any one of the organs that you see colored here on this particular screen. It can attach onto your heart. It can attach onto your liver. It can attach onto your kidneys, your intestinal tract. It can get into your blood vessels, which can lead to blood clots. All of that is happening. I don't know if any of you are sports fans out there. If you have an opportunity, go back and look at the interview that was by Stephen A. Smith that many of you know from ESPN. He was infected and gave an interview yesterday, gave several, and he was talking about how they were telling him that the virus was affecting his liver. I have transplant surgeons I've talked to. They say, yeah, the virus is affecting livers. It's affecting kidneys. It's affecting your heart. People have irregular heartbeat. So there are a lot of things that this virus can do. And so here I'm just showing that if you have a medical condition like diabetes, if you have high blood pressure, if you fall into generally the overweight or obese category, you have inflammatory proteins that if this virus gets in, it can actually rev them up at a much higher rate, and it can actually turn them on. Now, it's really important to understand that when the virus gets into your lungs, it's been that inflammation that leads to the pneumonia that people get, okay? It's been the inflammation that leads to that pneumonia that people get. And so if you have a medical condition, a pre-existing condition, that makes it much more likely that you're going to have a very significant complication. And so here on the left, I'm beginning to show some of the research that's indicating that if you get infected with the wrong variant, okay, so I have not heard this happening with Omicron. I want to be very clear on the left, but if you had Delta, if you had Alpha before that, or the original version, we're now concerned that people are becoming diabetic, okay, because now it's attaching onto your pancreas. That little receptor is in your pancreas, and it can help to shut down portions of the function of your pancreas from producing enough insulin so that now your blood sugars are going to go up. Here on the right, you all may have seen Dr. Vin Gupta on TV in the evening. He's a respiratory ICU physician out at the University of Washington. He was sharing what a normal lung should look like. And then you look on the right, you see what an actual infected lung can look like. Well, when you get that COVID pneumonia, okay, when we're talking about the different inflammations and the lung scarring that can occur. And here, the other thing people say, well, if children get infected, it's okay because, the death rate is much lower. Well, yeah, that's true. But children have the very same organs. And we're really concerned about a condition called multi-inflammatory syndrome in children. And it can affect all these different organs, and it can lead to a very significant inflammatory response in some children that can wind up causing them to be hospitalized and potentially causing organ damage. And this became very concerning when recently we began looking at children below the age of 18 and found that children who have been infected with COVID-19 actually have a higher prevalence of now new onset diabetes. Okay, the rate of diabetes in people under 18 was much higher in people who had been infected than people who had not been infected. And so we're monitoring in the scientific world and in the clinical world, we're monitoring all of this data. We're gathering and learning more every day. Things we didn't know 2 years ago are things that we're learning today, and we're sharing that with you. And here you can see, this came from the CDC, the number of children that became hospitalized. Now, again, back in late 2020 and going into 2021, we see these couple of spikes here. But the thing that really concerned me when I saw what we're looking at here was the rate, okay? This really high peak of children that were going into the hospital, secondary, in this case, to the Delta variant. And now we're kind of watching a very similar thing happen with the Omicron variant. So even though the death rate may not be higher with Omicron, it doesn't mean that it cannot affect you negatively. Actually, because so many people are getting infected with Omicron, we're finding more and more people that actually are sick enough to have to go into the hospital. And by the way, even before the pandemic, when people had the flu, many people would get from influenza virus, another species of virus. Many people would get sick enough to have to go into the hospital. So we're really concerned about that, especially from a pediatric standpoint. Here you're looking at the number of those cases I talked about with inflammatory syndrome. So we don't want to think that children getting infected cannot have any long-term consequence. They potentially can. So now I'm going to switch over and talk about how quickly Omicron and Delta spread. Here you're looking back in November 20th, and 100% of all the cases out there were the Delta variant. But as we move forward, all of a sudden, we saw Omicron come on board. And so in just about a 1 month time period from 11/20 to Christmas Day, we saw Omicron take over, and it became the dominant variant out there to the tune, let me get to the next slide here, where now is 98% of all the variants that are out there. So we have to really begin to really and truly understand that these viruses, these different variants, they're almost out competing each other. And we've never seen a variant spread more quickly than we have with the Omicron variant. Now, this is kind of, believe it or not, even though I just got this back on November 29th, and you see Omicron here, that one little red dot. Do I have the update? I don't have the update, I'm sorry. No, I don't have it just yet. Now, when I go and I did it this morning, I didn't have a chance to update the slide like I intended to, but now we have so many cases of Omicron all around the world. And so we're looking at, this is like what I call 23andMe or Ancestry.com, where they're looking at the genetics of the variant, they're looking and people are reporting it, and we keep a large database of it. And so Omicron started out as just a really small case back in late November, but now it's spread over around the world. I'm going to talk more about Omicron in just a moment. And so people often want to know, and I put, Dr. Austin, I put this in special for you, my friend. I don't know, it's just the entertainment value. But when we're doing research and you're trying to figure out how do we know all this stuff about these variants and what the variants do and how it's going to react in the body and trying to predict what may happen in the future, well, this is how we're doing it. We take that and they actually create these models. And they're electron microscopy models that begin to look at different gene pairs, and they're like zip codes. So we're going to think of it as being like a zip code. And so what you're looking at here on the left, that's the spike protein for the Delta variant. At the time that Delta came out, it had about 9 or 10 spike mutations, and we all kind of freaked out because we said, wow, we haven't seen a spike protein yet have that many mutations on it. Well, we move over, and the image on the right, this is the actual Omicron variant. It has, look how many more variants, it has about up to 50 different mutations that we're looking at, 30 of them meaningful. But there's something really unique, and I'm going to see if I can find it. Dr. Hill, can you, or Dr. Austin, can you all see my cursor moving on the screen?
Yes, we can see it.
Okay, so follow my cursor. If you come over here on the right side with this little red spot here, and you see that word INS, that means insertion. INS 214 EPE. This is what has made Omicron so unique. And let me explain to you what happened. What we believe happened is that the coronavirus, okay, some version of it, probably a very early version of it, it co-infected, in my case, just for today's sake, I'm going to say it co-infected a human being with one of those common coronaviruses I talked about, okay? So we had somebody or something, it could have been an animal, but I think it was a human being, that became infected with 2 different strains of the coronavirus, and one of them being very old, or the common cold version. And their genes began to mix up with each other. So there was a lot of genes and different proteins that were mixing together. And that insertion point is what we think actually led to the Omicron variant kind of taking on more of a more mild case of COVID-19. It actually infects the upper respiratory area much more. It does not infect the lungs nearly as much, or if at all, like the other variations did. And so now we're beginning to help people understand that when we talk about Omicron being different, we really are talking about the fact that somehow or another it emerged and all these mutations occurred that now allows it to replicate in our body much faster and spread much easier from one person to another. That's why we're calling it the most infectious version of any coronavirus or any COVID-19 virus that we've seen to date. And a big part of it came because that insertion gene right there, it informs us that it was co-infected with another version of it. And so our fear is that we may have additional co-infections, but with more dangerous versions. So even though we want to believe that maybe over time the virus is going to continue to weaken, and we are hoping, and I hope that will be the case, we are concerned that if, I do have it in there. We are concerned that if a more dangerous case of the Delta variant actually begins to co-infect people, that we may have a more dangerous thing. So we're not out of the woods yet. And so here, this is what I updated on the 11th. You can see more clustering of that red version on this 23andMe version of what I talked about. Now here, the one thing I want you all to pay attention to on the far right, you see all the different variants that are of concern that we have learned over the years. And so you see Gamma, was found in Brazil in November of 2020. Alpha, we found it over in the United Kingdom and England in September of 2020. I'm going to go down to Beta. We found it in South Africa in May of 2020. And the Delta variant was originally found in India in October of 2020. When you go back and take a look at Omicron, we just found it in November of 2021. But it emerged from one of these earlier versions. So this thing has been hiding out somewhere and in somebody or something for over a year before it became now the most dangerous and most transmissible, I shouldn't say dangerous, the most transmissible version of the coronavirus. We don't, and we're trying to figure out where has it been hiding for over a year. Because now when you talk about November 21, that's a full year beyond these other variants. But it didn't emerge from Gamma, it did not emerge from Alpha, and it did not emerge from Delta. So it emerged from an earlier version. So we have to pay attention to what that means. And we have people all around the world tracking that. And so I'm going to bring this to a close here in a moment because there's a video I really want to show you all, but people have a question right now. You know, if I take a test, you know, when am I infectious? You know, the CDC confused everybody. It said, you know, after 5 days, your most infectious time period is the first 5 days. And after 5 days, you know, if you're asymptomatic, you can go back to work. But, you know, we have this 10-day thing and maybe you can wear it for a mask for an additional 10 days. Well, it's all very confusing. I get it. Just want to show you here on the left that depending on what type of test you do and when you actually catch that virus replicating in your nose will be whether or not you even find it. And so part of the reason that the Biden administration is trying to get these home tests out to as many people is so that you don't do just one test. In order for that to work, you have to do two. You have to test yourself in both nostrils, by the way, follow the instructions. You have to test yourself on one day, and then you need to wait about a 48-hour period later and test and use a second test. So when you get your box, that box is for you. You may have a bunch of people living in your household. Unfortunately, they haven't figured out a way to give everybody one. But if people are symptomatic or if you're trying to figure out, am I safe to go back out? You need to test. Then you need to wait about a 2-day period. Then you should go back and test again. Because depending on where we catch the viral load that's sitting in your nose will determine whether or not that rapid test is going to actually work or not. Now, if you're going to do a PCR test, the deeper test, we can detect that for a much longer period of time. And depending on when people get that test done, it may actually indicate whether or not, you know, you're still infectious or not infectious. But you know, we do believe that more than likely after at least a 10-day period that you're not going to be infectious anymore. Okay, even if you test positive on PCR. And then over here on the right, I begin to show things where I'm kind of helping people understand that if you're not vaccinated, you have not had the opportunity to build up the full complement of antibodies. And therefore, if you become infected, in this case, this was happening some with Delta and then a little bit with Omicron probably. But you can see that people who were boosted had a far lower chance of going into, or of even having cases, by the way. This is the case. I'll show you the hospitalization in a moment. A much lower chance if you were boosted of actually catching COVID-19 than if you were unvaccinated. People that had 2 shots but did not have the booster, then you had a five times more likely chance of being infected. And then moving right here, this is still a case rate. I don't think I had a chance to put the hospitalization rate in, but all around the country, no matter what you look at, the threshold is like 88 to 90%. All the people who are in the hospital, 88 to 90% of them are unvaccinated. All of the people who go into the ICU, about 90% plus of them are unvaccinated. And then for people that actually die, that number goes up to anywhere from 90 to 92% of the people who were unvaccinated are the ones that die. So again, we want to help people understand much more of what's happening with the virus and what the benefits are of getting vaccinated. Here, very quickly, I kind of show that if you become infected, hopefully very soon, we're going to have oral medications you can take that will shut down some of that replication in the body, okay? If you all have questions about how that works, I'm more than equipped and ready to explain that to you. The main one that works the best is called Paxlovid, okay? So we want to make sure that, but there are now two oral medications that are available, and we're trying to get more supplies of them out into different pharmacies so that we can administer this. Okay, so now I'm going to show you all a quick video, and then right after this, I'll be happy to take questions that you all may have.
Coronavirus. Like many viruses, it uses a protein on its surface to attach to and enter our cells. Antibodies that fit onto this protein can block the virus from attaching. Coronavirus mRNA vaccines teach our immune system to make these antibodies. How do mRNA vaccines do that? mRNA is a genetic material that instructs our cells to produce proteins. The mRNA in the vaccine is wrapped in a layer of fat particles that protect it and help it get taken up by specialized cells of the immune system called dendritic cells. Once inside these cells, the mRNA does not enter the cell's nucleus or interact with DNA, but remains in the cytoplasm with other mRNA molecules, waiting to create the enzymes our body needs. When ribosomes read the vaccine mRNA, pieces of the viral surface protein are made. These pieces are then displayed on the surface of the dendritic cell. The dendritic cell travels to a nearby lymph node, where it presents the surface proteins to other cells of the immune system. Some of these cells, called helper T cells, train B cells how to make antibodies that will fit perfectly onto the surface protein of the virus. Other cells stimulated by the protein pieces, called cytotoxic T cells, can kill virus-infected cells. Now, when the coronavirus tries to infect us, our immune system is ready, immediately recognizing, neutralizing, and destroying it before we ever even have a chance to become sick.
So I know many people often believe that, well, you know, the vaccines were produced too quickly. I don't trust it. I get that. I understand. But I want to help people understand we have been studying mRNA vaccines for like 25 years. We've done cancer research for them for over 20 years. And to be perfectly honest, Moderna had a Zika virus vaccine. You all may recall the Zika virus. It was 97% effective, but Zika magically went away so quickly, they could not finish the phase 3 trial in order to get it onto the market. And so again, we just want to make sure that you all are, oh, here's one last thing, last slide. You may have heard that we now want people to wear an N95 or at the very least a KN95 mask. And we're expressing that now because of everything I talked about, because Omicron is so much more easily transmitted. We need to find a way to not only stop you from transmitting it if you have it, but we need to help create a barrier to give you an opportunity to avoid having it infect you. So I'm going to pause right there. Yes, I have been vaccinated personally. I have been boosted. My family has been boosted. I just wanted to share that with you all, so that you all have a confidence. And I'm not asking you all to do anything that I personally have not done or even had the confidence to do with my family. But I have had the background knowledge of understanding, excuse me, how dangerous this COVID-19 virus can be, especially for many of us in African-American and Latino communities. When we have a much higher prevalence of high blood pressure and diabetes in any group of people, if you become infected, you now have a much higher chance of having a bad outcome. And that bad outcome can persist for a long time period. It doesn't have to be gone in a 2-week period. Dr. Hill and I have talked with, I have my own patients who have had long COVID for over a year now. They had symptoms that have not gone away. So Dr. Hill, we're going to see if there's any questions or comments that people have, but I'll do the best I can to answer them. I hope I sparked a thought in many of you, but I want to thank you for your time during this lunch hour to learn a little bit more. I'm going to make some other comments here that I hope will be thought-provoking for many of you that quite honestly, if you're still worried or maybe even hesitant about getting the vaccine, I'm hoping I can share some other things with you that will at least enter into the equation that may help you make a different type of informed decision to go out and get vaccinated. Dr. Hill.
Okay. Well, thank you, Dr. Sneed. As usual, that was a phenomenal amount of information. And certainly the way you presented it was just on point. And I'm hoping that people walked away with some key talking points. I think you addressed several of the myths that have surrounded the vaccine issues and things related to the the pandemic and the infection. And so I'm hoping that everyone kind of caught that. I think the last video that you showed was also quite telling in terms of the value of the messenger RNA vaccines. But I think an underlying message that you had in there was that we still need to encourage people to mask. We still want people to get vaccinated, but we do understand that people still might be a little hesitant about it. And so one of the things that Dr. Austin has put into the chat for everyone is an opportunity for you and or someone you know to complete a survey to help us appreciate a little bit more, one, about how we can further expand our educational efforts and helping you understand what's going on with the COVID pandemic and how we can put it to an end. But also we want to appreciate any rationale or concerns that may be driving people's hesitancy in terms of getting vaccinated. If you were one of those late adopters, we also want to hear from you. And so there is an IRB approved survey. The link is embedded in the chat. You may also receive this separately as an email after this workshop. Dr. Sneed, we actually do have a few questions. But I want to start off first with Mrs. I think it's Malave, Yolissa Malave, to let you know that yes, we typically make our recordings available. What we are doing is putting them in the e-library so that you can go back and look at them independently. And we have established, again, thanks to Reach Up, an e-library that's actually hosted on your YouTube site, if I'm not mistaken. Dr. Austin can clarify that, but you can see not only this particular workshop, but many of the others that we've done. I think Dr. Sneed and I collectively are approaching somewhere between 150 and 175 presentations to people in the United States and even over as far as Africa and other places. And so we invite you to appreciate some of our best work, more recent work, so that you can get a clear understanding of what's going on. So that, again, recording will be definitely made available to you. So Dr. Austin, I don't know if you want to add to that comment. No. Mm-hmm.
Yeah, there were people who asked if I would be able to just send the survey link via email after this session, and I will do that just in case someone is not able to access it. I will also add the WeCare overview to that email. And then Dr. Hill, there was a question regarding the survey in terms of, is it only for those who reside in Hillsborough County?
Oh, not at all. Please share with the rest of the world. Yes.
Yeah, because I think it provides a opportunity to put your zip code so that we will know where those people are.
Yes, yes. So please feel free to share. So Dr. Sneed, one of the first questions that we have came from Amber, and she wanted to know if you could explain a little bit more about what you meant when you said COVID becoming endemic, E-N-D-E-M-I-C. Mm-hmm.
Absolutely. I'm going to write down Amber's name because we're going to have a little bit of fun here in a moment. Okay, so Amber, you're the first person. I just volunteered you for a little fun game we're going to play in a moment here. Yeah, Amber. So right now we hear the term pandemic, And typically, if you look at the actual definition of the word pandemic, it doesn't mean that it had to go worldwide or around the entire globe, but it tends to be something new and emerging that winds up infecting a lot of people or spreading to a lot of people over a regional geographic area. And it does so acutely, and it's pretty new. The word endemic kind of refers to the fact that, you know what, it's going to be around with us for a while. It just becomes a part of the circulating viruses and different things that we have to deal with over time. It just becomes part of our society and part of civilization overall. Our bodies have learned to deal with it. And by the way, the flu is something that the most common endemic thing that we think about. What we don't ever think about is the fact that when we tell people we have a cold, well, you know, a cold is a pretty general term, but the actual virus that causes the cold, the most common cold, is called a rhinovirus, okay? And a rhino meaning in the nose area. So these are just things that we're gonna have to learn to live with. We probably had an opportunity early on to get to that level of herd immunity and really knock down the levels, but two things happened. Number one, we did not vaccinate enough people around the world at the same rate, which is why all those variants are developing around the world. And we can talk more about that. And Dr. Hill, if you can make a mental note and have me come back to that towards the end. But then number two, we clearly did not vaccinate enough people early on in our country. We stalled out at about 57, 58% of people who were at the time eligible to get vaccinated. And so what that wound up doing is new variants began to emerge in our country. First the Alpha, then the Delta, and now Omicron. It just sought out and affected the people who were unvaccinated and then continued to transmit at a very high rate. And so now we just believe now that with other data that's coming out, Dr. Hill, you've heard me talk about the number of articles I read, which I'm not going to even mention that number right now, but over the past 2 weeks, I've read another 50 to 70 articles. Because, and Amber, this is going back directly to what you're talking about. I'm trying to get a better understanding now of how the body's going to respond and what's really going to happen and what's going to be the social impact. And so it is going to be endemic. It is now, we have very definitive proof right now that we think this COVID-19 virus is now being held in what we call a reservoir of non-humans, okay? A series of non-humans, as a matter of fact. And because of that, that means that it can be retransmitted back into the human population, which is not uncommon. I mean, all around the world, there's about 1 million viruses we haven't even detected yet. And none of them, the overwhelming majority of them, will never infect a human being, but some of them will. And so we're better trying to understand that. But in terms of the COVID-19, it's just going to be something that we have to deal with for a period of time. And so for people that want to get vaccinated, it's probably going to have an annual, not a booster. I don't like calling the word booster, but we'll call it an update. We'll be able to update the vaccine very efficiently, very effectively, and therefore that probably will happen for a number of years out. I don't know how many years, but it's certainly not going to be a thing where I don't believe we're going to be trying to give a booster every 6 months in the way people are talking about right now.
Thank you, Dr. Sneed. So I'm going to ask this question, and I'll ask Dr. Austin to kind of help me with some of the questions as well. So Ms. Calinthia Hobbs asked, how long do the antibodies last in the system after you have COVID? And also, should people obtain blood work after they've been infected?
Calinthia, I may ask you to, if you feel comfortable, you don't have to, but if you feel comfortable, ask you to unmute on the second part of your question, so I better understand exactly what that means. But as of right now, what we currently believe and what we know is that the antibodies will last for probably anywhere from a 4 to 6 month period, okay? So when you're hearing people talk about boosters and requiring a booster, it doesn't mean things didn't work. But what is happening is that if you don't continue to have the virus invade your body eventually is going to say, I don't need to continue to either manufacture or even maintain these current antibodies. And so the antibodies are like other red blood cells. They're not going to live in your body forever. Okay. Typically and usually your body has to find a way to remanufacture and have a reason. And our body responds differently to different viruses.
With getting her medical insurance in order.
Can we ask everyone to please mute your microphone unless you're asking a question? Okay.
Yeah, so Calinthia, at the current moment, we feel that antibodies are probably going to last for, in a majority of people for about a 5 to 6 month period. I do anticipate, however, that there are new vaccines coming on the market where they're going to last a little bit longer and they're going to have far broader coverage even than what we currently have today. And some of that great work is being done at Walter Reed Hospital with the in the Department of Defense research laboratories up near Washington, D.C., so in the Baltimore area. Now, as far as should you get blood work after, I can't think of a reason that you wouldn't get blood work. Okay, if you need to get blood work, you should go and get blood work, especially after you've had, gotten over the infection. So I hope I'm answering that second part of your question correctly.
Yes.
But there's no reason for you not to go and get blood work if you're going to get routine blood work, like your comprehensive metabolic panel, lipid test, or, blood test to see about hemoglobin, hematocrit, and, common things like that. I can't think of a good reason that you wouldn't get that.
Okay, thank you. That's the second part of my question was just a personal question to me. Just I do get routine blood work, but I did get COVID the early part of December, and probably like a week after I tested negative and everything, I have been having kind of a headache behind my eyes. It's very slight. It's nothing like damaging. It doesn't affect my everyday, but it was something that I'm just like, do I need to probably go back and just get some more blood work?
Yeah, I think it's certainly by now. Yeah, go and you get your routine blood work.
Mm-hmm.
There's no reason not to. There's no reason not to get it. I can't definitively say that make this point with you right now, but you may find that somehow your WBCs, the white blood cells, may be modestly elevated, but more than likely they wouldn't be. So I think you're more than safe to go get your blood work done.
Okay, thank you.
Very good. Now, I also put in the chat, everyone, that we will be sending a special token to the person that asked the most questions. So Dr. Austin is taking notes for that person. So we'll let you know at the end of the talk who that's going to be. Okay, so we do have a question by Juan Rea. He was double checking. He wanted to make sure now that people who are infected with the virus, are they now at risk for still developing other illnesses like diabetes, even when they no longer feel the flu symptoms? I'm wondering if he means the COVID symptoms.
Yeah, Juan, that's a great question, great point. And that's that's some of the long-term research that we're looking at now. Now we have to go back and follow and monitor people who have been infected. Part of my concern as a healthcare provider, as a primary care provider, is the fact that some of the organs that are being affected today, for example, the kidney. We know a lot of people wind up getting acute kidney injury. Now we're looking at the pancreas. Even though you may get over the illness today and feel fine, did the virus actually potentially, and it's not definitive, Juan, so I don't want you or anyone else to panic. It's a question we have. But did it possibly zap some of the resilience of that organ so that one day it's not functioning at 100% at some point in time in the future? We don't know. But it's now a question, knowing that the virus can attach onto all these different organ systems in a way that we have never communicated to the public. We've never really communicated that to the public. Now, Dr. Austin and Dr. Hill, they've been with me from the very beginning. They've been hearing me say this for over a year now. But now we're watching, and Dr. Hill, did you see the graph I put up from the MMWR about being less than 18 and the diabetes rates?
Mhm, mhm.
So now that's the kind of research and the epidemiologic research, and looking back over time. Now we're beginning to question what else should we be looking for in terms of potential damage. And so Juan, that's exactly what I meant. Even though you've gotten over the symptoms, you're fine, you're moving on with life. We still know that we have to monitor some organ functions for a period of years to make sure that somehow the overall resilience of that organ is not being affected negatively.
Mhm. So, Dr. Sneed, what you're saying is we don't know how long the long haul symptoms actually mean for people who get infected. And I think to add to that is, whatever individual factors they bring to the table, like you commented, high blood pressure and things of that
Yeah.
nature, they might be more predisposed because of some of those factors.
Absolutely. Dr. Hill, and these are the kind of conversations that, many people in the public don't have a chance to be a fly on the wall with between two scientists like you and I. So let's show them how that looks sometimes. But, Dr. Hill, the number one thing now that I truly believe is that we should do everything we can to prevent the virus from attaching on to the organs to begin with. I mean, listen, it can be me tomorrow. Anybody can get infected with this virus. Okay, it can happen. But what we want people to actually, I'm going to admit these two people here. We actually want people to potentially get vaccinated so that you have an antibody army that can attach on, just like in that video at the very end, it can attach onto the virus and it can cover up those spike proteins so that it doesn't have a chance to not only attach onto all these different organs, but it doesn't have a chance to replicate, because even if a few attach on, if it doesn't have a chance to really replicate out of control, we think we can have that organ preservation in the long term. But if we allow it to just replicate out of control, we don't know from one person to the other what potentially can happen with them. And so I think you're exactly right. And by the way, Dr. Hill, I think you're going to be very interested to know that the psychological and the psychiatric impact of not only COVID-19, but now directly attributable to the virus is now gaining much more attention. Again, another long-term ramification of dealing with these with the different viruses. So again, Juan, I think as a matter of fact, I'm gonna write Juan down here. Okay, he's number 2. Okay, he's number 2. Juan, you're gonna help us play a game here in a moment for asking and sparking such a great question about our concerns from a long-term healthcare standpoint.
All right, so I think Dr. Austin, looks like Mrs. Kimberly Ward, she wanted you to go back to and explain the slide with the boosted versus vaccine versus unvaccinated. I think it was kind of on the end, and the likelihood of getting COVID, because she was in the impression you were saying that they were more likely to get it. But I think what you were saying is the unvaccinated people were more likely to get it. But if you could go back to those slides.
Yeah, you want me to pull it back up, or can I just explain it, Dr. Hill or Kimberly? You let me know.
Yeah. Your call. You're driving the car.
Yeah, well, again, it goes back to the comment I just made, Kimberly. What we're doing with the vaccine is it's kind of like we're priming the pump and we're training an army. The time that you want to start going out and recruiting, an army is not after you've been invaded from people from another country. You want to have already trained an army or law enforcement or firefighters or anyone that we charge with trying to protect the public. You want to train them before there's a problem. And what the vaccines do is that they recruit and train the immune system so that we have an antibody army waiting ahead of time so that if you do become infected, we can minimize the impact of it. Now, back to your real point with that graph, what we continue to find are that people who have been vaccinated and boosted have the lowest opportunity, even though all of us can inhale the protein into our nose, as I showed in the very beginning. When that protein when the virus protein gets inhaled, you have an antibody army waiting to just arrest it right then. And it doesn't spin out of control. For people who were vaccinated but unboosted, remember their antibody levels began to kind of slowly go down over time, and they came into contact with the virus. Now your body is primed to be able to get the antibodies built up quicker. But Dr. Hill, I didn't mention this during the presentation. For everyone listening, I want you all to hear these numbers. When we had the original version of COVID-19, that became ground zero for how fast the virus can replicate in your nose. When we got to the Alpha variant, okay, what used to be called the UK variant, we found out that replicated 100 times faster or more than the original version. And when we got to the Delta variant, we found that the Delta variant replicated inside of your nose 1,000 times more than the original variant. And now we're dealing with Omicron that we know replicates 70 times faster than the Delta variant. So Kimberly, what I'm saying is that if these things are overwhelming our immune system, and they're replicating so much faster over time because they have learned the human body so well. And if you're not vaccinated, it still is going to take your body that 7 to 10 day period to ramp up enough antibodies to protect you. So more people become sicker quicker, okay? More people become sicker in a more intense fashion than they did before. And that's why we have watched the hospitalization rates just skyrocket all over the country every time we've had a surge. And that's why we encourage people to want to get vaccinated. Now, we understand, and Dr. Hill and I, we talk to people, we understand many people are still hesitant and do not want to get vaccinated, and we respect that. But the data, what we're presenting is showing the data for what it is. So that's a great point, Kimberly. Thank you very much.
She's also inspiring us to start doing something a little different. We've not traditionally shared some of the literature or the citations and references with a lot of our talks, or they're embedded like in the slides and that kind of stuff. But she asked, where could we find literature regarding kids and the COVID vaccine and possible effects on fertility? So I wanted to first invite Ms. Ward to check out our e-library. We have several presentations in there that at least you could verbally appreciate some of this stuff, but we can definitely work and have maybe our student ambassadors pull together a nice impressive list, and we'll have to beg and plead with Dr. Sneed. If you all continue asking questions, he might share some of the articles. He didn't want to tell you how many articles he's read, but I'm gonna tell you that it's less than 1,000 and more than 500. So that's just a clue as to the bank of information that he has under his purview. And so certainly we'll be more than glad to share some of that with you as we get it a little bit more organized, and I can't appreciate if you're a health professional or not. So we want to make sure that it's in a format that you can absorb. Okay, but thank you for that question. Mrs. Candace Simon gave you a compliment, Dr. Sneed. She says she's always learned something new when she listens to you. And so that's good. But Dr. Austin, they're asking questions, so I hope you're giving them
I
okay. So Mrs. Kiona asked, for individuals, particularly those working at Reach Up, they're in and out of homes and interacting with patients in many ways. And they were curious about your recommendation for them in terms of the CDC guidance. And I think you kind of touched touched on it a little earlier, but that was one question. The other one was the general community guidance or the healthcare personal guidance. And then should the specific guidance apply to the whole organization or just to specific staff? So that was kind of a multi-layered inquiry regarding the CDC recommendations, as far as prevention. Mm-hmm.
Yeah, it gets a little, it's been very tricky, and one thing I'm going to share with you all right now that you all may not all the way appreciate at the level that I'm going to say it about your one of your fearless leaders here, Dr. Deborah Austin. She's one of the top public health officials you're going to find anywhere in the state of Florida, maybe all of America. She sits on PhD candidate committees. So she's helping to train the next generation of public health officials at a very high rate. And the reason I bring it up that way is she will be the first one to tell you of the discrepancies and the conflict that occurs between some federal guidelines and state guidelines. Mm-hmm. Okay, they're not always going to agree with each other. And so very often it puts a company like ReachUp kind of in the middle of trying to fairly interpret what needs to occur in order for them to run the business at the level that they really want to run it. And so the only thing I can share with you is that if you take a look at the CDC guidelines, if you take a look at our current state guidelines, there's one very clear thing. I think all are gonna, and by the way, the policies of ReachUp as a nonprofit interfacing with the public. So we have to take that triangular approach. At the very least, number one, we're going to expect people to wear a mask. At the very least, you cannot put other people at risk because you feel uncomfortable. Because remember what I have shown you, you can be infected, you can be spewing out virus long before you knew, long before you became symptomatic, and long before your body even knew you were infected. Especially now that we have Omicron and Delta replicating at a rate of 1,000 times quicker and 70 times more than that than the original version of this virus. Mm-hmm. That means that you can go out and infect people and not even know it. And now they become severely ill, go in the hospital and have complications. And you may not even know that you were the one that did it. Mm-hmm. That comes back to number one, why we clearly want people to get vaccinated if possible. Okay. Now, I'm not going to get into the politics of that. I'm not going to necessarily directly talk about the Supreme Court ruling that just came out because if you don't have a pseudo legal background like I do, that's a funny statement, isn't it, Dr. Hill? Where you take an interest in trying to read those kind of things, which I have done. I read the report that came out from the Supreme Court. What winds up happening is that you can cherry pick almost any part of something to try and apply it 100% to yourself and justify why you think you should be able to do something or not. Mm-hmm. And so it becomes that cherry picking of different bits of information. That's why collectively we want to educate people about the benefits of protecting you and protecting people next to you, and then understanding the ramification of that. And so I know I'm kind of not directly answering the question about should we follow this or that. I think what companies are going to do is they're going to evaluate all of that information. They're going to take a look and see what is our core mission as a company and what components of all of that can we do to make sure that of two things, maybe even a third, but there are two things. Number one, how can we meet the core mission of serving the public and keeping and not being responsible for infecting the public? And then number two, and maybe just as important, how can we protect our workforce so that we don't have to actually have people calling out sick, and going into the hospital, having rising insurance costs and all these other things that come along with the workforce becoming infected. Mm-hmm. I'm going to pause right there. Dr. Austin, did you want to add on anything to what I just said? Because
yeah, I see,
the whole federal state thing.
Yeah.
It's very, very, very difficult.
Mrs. Barry has her hand raised.
Oh, okay. Yes. Yeah. Dr. Barry.
Yes, mine was mainly a closing statement, but to you all, but in response to the question that was just raised, and I think you responded the way in which we proceeded with Reach Up and our identifying what our three priorities are. And those three priorities are based in our work and our alignment with our board of directors guidance as far as how to preserve the health and well-being of our staff. And so there are some policies that have become more user, as I say, more user friendly and or applicable to us because of who we are, what we stand for, and what we do. So it will be there will be some derivation and differences depending on who's the organization, what's your mission, and what's your function in the community as a whole. So I just want to say thank you, We Care, for extending this session update to our Reach Up family. And Dr. Hill and Dr. Austin, you guys, organization and implementation is exemplary as always. And for our new employees, and we have quite a few, Dr. Austin, who I call Doc, is Reach Up COVID resident specialist, among other things. And you can always have conversations or communicate with her. And to dearest Dr. Sneed, and I do call you behind your back, our Dr. Sneed. As old folks say, you something else. Dr. Hill mentioned several attributes and qualities for you, but I want to add one more. My staff know I talk about this all the time, and we also, I say, fortune teller. You have been 100% accurate thus far about warnings, about concerns, about strategies, how we should mitigate the spread of COVID and variances. And that has guided Reach Up with our response to COVID in a corporate fashion. So thank you so much, and please keep informing and educating us in really understandable fashion. And Reach Up will continue being an effective, true partner. Thank you.
Well, Dr. Berry, thank you so much for that. Reach Up, you all a family now. As a matter of fact, I'm sure you saw that, I wrote a piece for a national publication recently, and I kind of made Reach Up one of the focal points of what should be happening nationally, the type of partnerships that need to happen nationally. And I made you all really the focal point and really the epitome of what that means. So I just want to thank you and everybody here from Reach Up. Listen, Dr. Hill, we got a few moments here. I want to address, I went through and looked at the chats. Let me kind of wrap a few of those together, a few of the questions together, just very quickly, because I just want, I'm using this as a test case for something else. I want to have a little game here in a minute.
Okay.
So it might seem corny to you all, but I apologize, but I have to test things out before I go and do it bigger than that. Maribel had a very good question here. She was asking about her friends that are vaccinated, non-vaccinated, and saying all of them have very similar symptoms. Maribel, hopefully you were there kind of earlier on when I showed the two spike proteins side by side, and I talked about that insertion gene. I want you to think of Omicron as being almost the midpoint between a common cold virus and the really dangerous version of the Delta variant virus. It's kind of in the middle, because what we found is that the Omicron variant, it doesn't have the capability of replicating very well in the lungs. It only replicates very well kind of in the upper respiratory parts of the body, okay? And so the majority of symptoms that people are going to feel are going to be just like the quote unquote common cold. Okay, it's going to be a stuffy nose, runny nose, sore throat. There'll be some coughing that can occur with that, but the coughing won't come from that intense lung inflammation. However, what we are finding is that for many people who are unvaccinated, because the virus can replicate at such a high rate, that it can lead to other components of people becoming ill enough to wind up going in the hospital. Fortunately, when they get in the hospital, for the number of people who are actually in the hospital across the entire country, we're not finding the high necessity for being on high flow oxygen for being put on mechanical ventilation, for being put on what we call ECMO, where we have to take the blood out of your body and put it into a machine to oxygenate it and then put it back into your body. The very significant lung scarring, we're not finding all of that part happening. And so it's still important that people get vaccinated, which leads me to another point I think Kimberly was asking about. And let me make sure everyone understands. The current vaccines that we are putting on the market are synthetically made proteins. There are no other proteins in there. There are no fetal cells in any of these things. We can 100% assure you of that. 100%. As a matter of fact, if you look at the ingredients in either Moderna and or Pfizer, the majority of the ingredients in there outside of the mRNA strand can be found in your kitchen. Sodium chloride, sucrose, potassium chloride. These are things that are commonly found, so let's make sure we understand that. But the other thing we do know, when you get vaccinated, because we have engineered it in such a way that it can activate even other parts of your immune system when you need them, meaning the memory portion of your immune system, okay? Mm-hmm. When you get naturally infected, what we're finding, there's a lot more variability from one person to another in terms of what part of the virus did it read in order to accomplish building those antibodies. Well, we take all that variability out when we vaccinate you, because we have 100% aligned that vaccine to the spike protein on the virus. And so even when, now everybody's going to have waning immunity, but it comes down to what part of your immune system remains on stand alert and what part of your immune system just dies off and it cannot be activated anymore. And so vaccines and the current mRNA vaccines are clearly superior and are showing every day. There have been 7 articles over the past 2 weeks that have specifically talked about that, and I'll try to remember to give you, Dr. Hill, some of these articles. Now, when you get them, you're not going to understand them all the way, but that's okay. Read the abstract, and you'll get the gist of what they're trying to say. So I'm going to try to remember to get some of those articles out to many of you. So let me just play this game real quick. So Amber, are you still there?
Amber said yes. She said yes.
Okay, Amber. Okay, so okay, is Juan still there? And how about Maribel? Juan, are you still out there?
Yes, I'm here.
Okay, so listen, Juan, are you less than 21 years of age?
I wish.
Juan, okay. Did you happen to see the movie Ocean's 11?
Yes.
Okay, Amber.
You're talking about the new ones or the one from the
No. I'm talking about the old ones with George Clooney.
Okay.
Yes. So Amber, I'm gonna give you all an example of what the virus does in your body. I'm gonna use the 4 of us. I'm gonna put me in there too. Okay.
Okay.
So Amber, you just became I'm going to talk about non-structural proteins. I showed you that little thing in the beginning, but we're going to shorten that to an acronym, NSP, okay? And so you all are now my NSP team. All right, so Amber, you are NSP number 1. Juan, you are NSP number 6. And Maribel, you are NSP number 13. So let's imagine that reach up as an entire group, all of us together. You know, today we have 60 people on here. We all got together in a hotel, and we're going to have a retreat in a hotel. And we're going to break up into 16 different groups. Okay, 16 different groups, and every group is going to have a group leader. Amber, you are group leader of group number 1. Juan, you are group leader of group number 6. And Maribel, you are group leader of group number 13. Now I'm the one directing. I'm the bad person. I'm the RNA strand. And what the 3 of you are going to do, you're going to grab your little group, and you all are going to, and remember, we're in a hotel. You all are going to go all throughout the hotel, and you're going to knock out the cameras so that the security can't see what's going on. Okay, so Juan, you're going to knock out the cameras in the elevator. Maribel, you're going to go knock out the cameras in the lobby. And Amber, because you started this whole thing off, you're going to go into the control room, and you're going to knock out the cameras in the control room. So now security can't see anything in the hotel. Now, all the other groups, remember there's 16 groups. I'm going to assign all of you to go out into the hotel and do different things. Some of you are going to go and you're going to steal materials. Some of you are going to go steal some food. Some of you are going to go grab some blankets. And then others of you are going to go and recruit other people in the hotel to come down into the conference room where 60 of us are. Now, I'm going to say, okay, now go. And all of you are going to go out. But the number one thing that has to happen so that all the other 13 groups don't get caught is that Amber, Juan, and Maribel have to knock out the cameras. And then in a period of time, we're all going to come back, and all of a sudden, where we only had 60 people, now we got 6,000 people. We went and we emptied out the whole hotel. We got people, the employees, we got everybody. We've now built the army. And now I'm going to repackage all of you into virus particles, and we're going to all escape out the door, and we're going to go to the next hotel, and we're going to do the same thing over again. And we're going to keep doing this over and over and over and over and over again until we get caught, until the police and the SWAT team and a whole bunch of people come in and they finally arrest all of us. Now, what I just described to you, I think you all understand, this is what the virus is doing to our body. We have these non-structural proteins, 1, 6, and 13. Their job is to knock out the cameras in the body so that the rest of the proteins can go and do all this bad stuff. And then we're going to pull everyone back together, and we're going to grow the numbers, and then and then it gets out into your body to go and reinfect other organs. And the more people that we recruit means the sicker the human body is going to get. And the only thing that will stop that is to actually have enough law enforcement around to arrest us so that we will stop ransacking all the hotels. That's the benefit of the vaccine. We need to have the law enforcement there at the very beginning, even though Juan, Amber, and Maribel, they're still going to do that thing in the beginning. We're going to catch them pretty quickly, but more importantly, we're not going to allow everything else to happen. So when we're talking about people getting vaccinated, this is what we're talking about. If you happen to become infected and you fall into a high-risk category, we want you, if you can, to go out and get the monoclonal antibodies. That's like filtering in the army. But I don't like the fact that you've already been infected enough to have symptoms, because now that means the virus is attaching onto your organs. Also, if you become infected and you have symptoms, we want you to go, if you can, get these medications, the oral medications, so that you can do this stuff. So anyway, I just wanted to try and explain it a little bit differently with a little bit of fun. So Amber, Juan, and Maribel, you all are now part of my NSP team. Okay. But now we understand better how this particular virus has learned to evade our immune system, and why it has spread all around the globe, and why we are concerned in science that it may continue to evolve. And so we have to stay ahead of it. That's why we're doing all this research. And so if you all have the opportunity to please go and answer the questions and even give it to other people. If you can answer the questions, that will become another part, a key part of helping us to better understand how to combat the virus so it won't go out, and we can better educate people and understand how to communicate better. But anyway, you all are part of NSP, my NSP team now. It's the second time I tried it. And so on Dr. Hill, every time I give a presentation, I'm going to try and build my NSP team up.
Okay, awesome, awesome. Well, we did have a few hanging chats, so to speak, a few questions. Mr. Pittman actually asked two. I think you kind of addressed one about the need for us to have the annual, probably, look forward to having annual COVID vaccinations. But then he had a second one regarding the variant of the flu and Omicron and the lasting effects. And I don't know if you I don't think you addressed that too much. Yeah.
Yeah, no, I listen. I've been paying attention to this combination flu Omicron vaccine for a little while now. I just did another. I've been fortunate to go on Black News Channel as a kind of a correspondent. I just did it yesterday, talking about it. It's in development. That the clinical trials. I'm trying to get them here at USF now. That won't be out until 2023. But to really answer your question again, because of the endemic nature of what we're talking about, and because if you really think about it, every year now we've developed pretty much two variants a year that are pretty dangerous. We anticipate that for a period of time that we are going to have to get an updated version of a vaccine. So but what I'm not advocating for right now is this fourth shot you may be hearing about. I'm not advocating for that because right now I'm not sure we need it. And I think Omicron is going to burn out by the end of February, such that we won't need to go and stimulate the immune system one more time. The next time I get a shot, I'm hoping it will be for a much more updated thing against a much more dangerous version of the coronavirus. Because right now, if we had to pick one Omicron or one variant, Omicron was the right one because, again, it's infecting a lot of people, it's making a lot of people sick, but it has turned out not to be nearly as deadly as Delta overall, and it's not nearly as dangerous as Delta. And so, but please keep in mind what I said. Even all the people who have been infected with Omicron today, it is not going to confer protection for you forever. 3 to 4 months is probably all we're really going to get from Omicron. And then after that, your chance of getting reinfected will go up. And you may get reinfected with an evolutionary version of the coronavirus that may escape all of everything. And so at that point, if we detect that, we will need to get an updated version of a vaccine. So be ready for that, but don't let it cause fear. The very last thing I'll say, and I know we're past time here and I have to go to a meeting, but here in Florida, we learned, if you have a body of water near your house, you probably have a little baby alligator in that water. It's not uncommon to find little alligators or some little reptile out there. We don't allow that to keep us from going outside of our house. We actually learn to live with it and we know what to look for. So I don't want people getting all this anxiety, because we're looking at it every night on the news. Let's protect ourselves. Let's wear a mask. Let's get vaccinated. If you become infected, because there's a great possibility that can happen, let's understand what the therapeutics are with the monoclonal antibodies. And there's only one, by the way, that's really effective against Omicron right now, and it's in short supply. We have the oral medications coming on pretty soon. Let's learn to protect ourselves, and then let's try really hard not to infect other people. We cannot allow that to happen. You can't walk into somebody's house, and even if you think you're masked up, the mask is not 100%. You may still allow virus to get out. We don't want to infect a person to our left and to our right. Let's learn to watch out for each other. But Dr. Hill, I'm going to turn it back over to you and Dr. Austin. I want to thank all of you for your time and attention today. I can talk about this all day because I generally do talk about it all day sometimes. But if we need to come back for an update, a month or so from now, I'll be more than happy to do it because I owe so much to reach up. I owe so much to Dr. Austin. I owe so much to Dr. Berry. I owe so much to all of you for allowing me to get out into the community and really do the work that needed to be done to save lives. Thank you very much.
Well, thank you, Dr. Sneed. And certainly I was going to say, this has been a great group. They asked some wonderful, wonderful questions. And so Dr. Austin's going to let us know, as she has the closing comments, who was the one that will be getting the gifts, and they'll get the address to her so that we can get everything to her. But again, we want to remind you, if you're interested, to please complete the survey so we could appreciate anything that's holding you up from considering the vaccine, or someone you know and love who you know needs to get it. And if they've had COVID and are still not vaccinated, those are also good individuals to have complete the survey so we can kind of understand what's really going on, so we can develop more great programs like this. So with that, until the next time,
Wait. Dr. Hill, I got to thank you. You are the hostess with the mostest. You know, you probably deserve your own TV show, to be honest. I just want to say that publicly, if I haven't said it publicly before. But thank you so much for being a partner along with me during this journey, and I'm very thankful for you as a professional and as a friend. Thank you so much.
Oh, thank you. My pleasure. My pleasure. Well, Dr. Austin, we'll turn it over to you and let you close us out. Who asked the most questions today?
Great. Thank you. One of the things that I did, of course, I closely checked the chat.
Okay.
There were times when people asked different questions, in one chat. So the person who actually asked the most questions was Kimberly Ward.
Okay.
And close tied to Kimberly was Maribel Rodales. So Kimberly Ward is our winner.
Awesome.
All right.
So great. And if you all have any more questions, feel free to reach out to us. In that overview, we have our email address. And so please just let us know if you have questions. So with that, we will let everyone get on with the rest of their afternoon. Please take care. And Ms. Ward, send your mailing address, please, to Dr. Austin so that we can get your gift. And congratulations. Everyone be safe.
Okay. Everyone take care. Have a great day.